Yeah. Let everyone know they're being recorded. Yeah. Okay. So thank you all for joining us at OMSAS here on this Monday morning. Sorry that the primary contractors, county mental health administrators, and BIMCOs got the 9 o'clock slot. That is the meeting that you are attending. So we have at 11 o'clock a meeting that's just for providers, and at 3:30 another one that's for peers and family members. So hopefully, I mean, all the faces I see, I know they're in the right place. So so it just, keeping in mind, instead of doing a webinar, we're using a Teams meeting so that there can be conversation after I go over a few slides. But there's two ways to engage in conversation. If you want to, raise your hand, we all know Teams is lovely because it numbers it, so we all know who goes in next. Or put things in the chat function. I do have Shivani and Barry with me. Both of them are employees of the Bureau of Policy Planning and Program Development to help me manage this process. So Shivani, if you can move to the next slide. I didn't make those fancy transitions, obviously. So if we haven't met before, I'm Dr. Jenna Maynard Baker. I'm the Bureau Director for Policy Planning and Program Development. Somebody's not muted because we're getting feedback. So we're going to talk today about telehealth. Our goal is to have a conversation about positive change for telebehavioral health services. We're going to go over what are our responsibilities, backgrounds, current regulations, and challenges. And we are mostly focused today, although the conversation, it doesn't have to be exclusively focused. What I'm going to talk about in terms of regulations is largely focused on psychiatric outpatient clinics. But the comments you want to make or the discussion you want to have won't be limited to that. Next slide, Shivani. So obviously, our responsibility at OMSAS is promoting access that supports choice to services for beneficiaries that best serves their needs and are delivered in a manner that they prefer, the individual receiving the services prefer. That we license a variety of services and support services to ensure health and safety standards are being met for peers and families. Because for me, that's, for all of us, that's really critical. And also working to prevent fraud. It's our responsibility for ensuring appropriate verifications are secured to prevent fraudulent billing of the MA program. Next slide, Shivani. Okay, so what do we mean when we say telebehavioral health? So telebehavioral health is actually defined in the psychiatric outpatient regulations, since those had an amendment pretty recently. And it is real-time, two-way communication in which both parties can see and hear one another. So audio only is a totally different classification than telebehavioral health. Audio only is obviously audio only, where you can only hear each other. Audio only is prohibited within psychiatric outpatient clinics, specifically in the regulations. So then what are outpatient psychiatric services, right? We know what those are in terms of assessment, medication management, individual and group therapy. And then how does the term, and I don't mean to tell you things you all know, I just want to level set. The term clinic relate to these services. So psychiatric outpatient clinic services requirements are outlined within the clinic category of the Pennsylvania Medical Assistance State Plan, and CMS, the Centers for Medicaid and Medicare Services, have very specific requirements for services that fall under the category that are categorized as clinics. And I do want to say that we have had a recent conversation with CMS about that and about any plans they have for flexibility related to services that fall under the clinic category, and they are not planning on any flexibilities for that. Next slide, Shivani.
Let me ask a question.
We can ask a question when we get to the end. Is that okay? Or do you?
That's fine. That's fine.
Just so I might answer it. That's my only thought.
Okay.
So let's talk about both the state and the federal regulations that govern what services are permitted, staffing and reimbursement for the telebehavioral health within, largely psychiatric outpatient clinics. But when we talk about the psychiatric outpatient clinic regulations. Next slide. So these are the federal Medicaid payment regulations. I think many of you have heard me talking about the fact that as we build the crisis service system, we need we need a licensed professional to recommend crisis, the deployment of a mobile team, and people have commented that that's new. That is a long-standing federal payment requirement. So these are the federal payment requirements specifically for psychiatric outpatient services. And so the clinic must be at the direction of a physician. And and there are rules. The four walls rule is in effect, which is that either the provider, which is in 42 CFR 4490, and that either the provider or the service recipient must be in the clinic at the time the service is being rendered. It is not possible for both parties to be outside the clinic and the service be billed to MA. So that is a federal requirement we cannot change. Just the requirement that it must be under the direction of a physician is a requirement that we cannot change. The direction of a physician, we'll talk about that in a minute. And we asked, and this is the conversation we had with CMS, there is no possibility to transform a clinic service into 100% telehealth services where both the recipient and the practitioner can be located outside of the clinic building. We have to have a service that falls under a different category of the state plan. It is not possible for psychiatric outpatient clinics, which are under the clinic option of the state plan. Next slide, please. So what does our state regulations and statute say? Here, the requirements of the supersede, our requirements supersede any different, technology. So telehealth technology, it is for telehealth technology, it is permitted in clinics is only interactive audio and video communication. You can't engage in other ways. Next slide. Staffing patterns require the following right now in state regulations. 50% treatment staff providing shall be mental health professionals. Psychiatric outpatient clinic is required to have 2 hours of psychiatric time per week for each FT, mental health professional, and mental health worker providing clinics. And a psychiatrist must provide 50% of the required psych time currently at the psychiatric clinic. Although that is a waiver that I think many of you know, we have been allowing the advanced practice professional to provide the time at the clinic and the psychiatrist to provide the time via telehealth. That is, next slide. So these patterns, the advanced practice professional may be doing the part, as I just said, that was via telehealth. But we have allowed them to be the in-person and the psychiatrist to do the telehealth part. So we have been able to issue that waiver that allows that flip-flop from the advanced practice professional and the psychiatrist to switch who's doing which parts. But as you can see in the federal requirement, the psychiatrist is not required to provide any of the required psych time. The the physician is required by federal law to have clinical oversight of the clinic. So that's a difference, just so folks are aware. Next slide. So I think we realize that there's our regulations, and then there's just the rigidity of back forward again,
Sorry about that.
forward again. Yeah, there we go. The regulations and rigidity. So like we said, we had a call with CMS, and they said that, they would not be changing the 4-wall rule. We have different requirements for payment and staffing. This is now when we talk about all, but the rigidity of the federal government is especially in place for psychiatric outpatient. But we have different payment and different staffing requirements based on the service type. So it's not easy, anything that has federal regulations connected to it. Trying to striking a balance between the kind of antiquated pre-COVID practices and COVID and post-COVID practices to try to protect the health and safety of peers and ensuring choice. I think that we probably all have heard stories of individuals who are being told that they can only access care via telehealth, or providers providing audio only for services that audio only is not actually permissible for, and consumer access to, peer access to necessary tools, making sure that they have access to audiovisual devices, broadband, cellular service is a challenge in certain areas of the state, absolutely. So these are sort of just some of the challenges we face. Next slide. So this is really me done talking. I wanted to get through that. I think the outpatient psychiatric clinics are the regulations for which we get the most waiver requests, including 100% telehealth waiver requests. And, it's important for folks to understand that a clinic service can never be 100% telehealth service. That would need to be a service under the rehab option of the state plan. So the questions I have now for a conversation with all of you, is, do you think service type should define what services can be delivered via telehealth? And when I say telebehavioral health, it is not audio only, that is separate. What about high acuity services? Should they require more in-person services than low acuity services? And then the other question is, do you think service type should define what percentage can be delivered via telehealth? So if folks have comments now, I know I stopped someone earlier who had a question. If folks have questions or comments they would like to offer, or questions about what I shared about clinics, services, floor is yours. Yes, Beth.
So thanks, Jenna. So going back to the beginning, just to translate for me, this presentation is specific to what we in managed care would call a provider type 08 specialty 110, a psychiatric outpatient clinic, which is licensed under the outpatient psychiatric clinic license rubric.
Go ahead.
It is not intending to address independently contracted psychiatrists, independently contracted LCSWs, so on and so forth. This is specific to clinic.
Well, the regulations, so when we get a lot of comments about we just need to be, have 100% telehealth and let everything be. And so the service that has the most strict requirements are psychiatric outpatient clinics. And so the point of pointing out those federal and state requirements, especially the federal ones, is just so folks realize that that's the one with the most kind of strict guidance from the federal government. But these questions are not specific to that.
Okay.
So we have had, we want to make sure that everyone is clear on what can and cannot happen within a clinic service. And that CMS never waived that someone must be in the building, even in COVID. And so we just want to make sure that people realize now that either the practitioner or everyone is mindful of either, of what is and is not permissible under federal regulations for psychiatric outpatient clinics, because they are the most regulated by the feds in our land and the things we license. And these questions, though, are not specific to that. These questions are more general.
So just going back to the beginning part of the presentation, to be sure I understand. So the part that was being stressed was that when rendering telebehavioral health under the clinic option, either the member is in the clinic and the practitioner is outside somewhere. Even what if it's in another clinic?
No, they have to be inside the same it's called the 4-wall rule. They have to be inside the same 4 walls. I mean, one of them has to be in the walls of whatever clinic. If the clinics are connected, I don't think that matters, but that's a really good question. No one's asked me before.
Yeah.
But the idea is that it is a clinic service, so
Mhm.
either the provider or the recipient is inside the clinic at the time the
Correct.
service is delivered.
Okay, so
Yes.
the member can be in their home and the
Mhm.
provider can render telehealth place of service, I don't know, O2, whatever, whichever one it is. But the provider, the person rendering the care is inside the clinic walls.
Yep, or the other way
Or-
around.
Or the other way around, the member is inside the clinic walls and the practitioner is in some external location somewhere.
Yes.
I guess the question I have is the rule regarding must offer face-to-face. So if we have a clinic that's in Erie, Pennsylvania, but the member is in Chester County and the member wants that provider and that provider has no opportunity to offer in-person, face-to-face telehealth, can that
Well,
continue? Because they're meeting these
yes.
rules.
Yeah, it's if the person wants, if an individual, the challenge here is that telehealth can be a great convenience and barrier removal for people seeking services, right? They don't have to find transportation, they don't have to deal with childcare, they don't have to, they have just a
Right.
lot more flexibility. However, the concern is that we've also gotten calls from folks who want in-person services and been told that they don't do that anymore. And so, or that they have to have literally outpatient psychiatric services via audio only. That's not a thing. That's just, if you read the regulations, it's not a thing. You can't.
If a member is fine with
Yep.
100% telehealth, we are permitted to allow that. Because that's
Yes.
not been our interpretation. Providers who have requested to come into network who say, I only have a location XDX miles away. I have no opportunity to offer in-person to members. We have said we cannot bring you into network
Well,
because of the understanding of the rules.
the issue is for us, and I'd like to see what rule you're talking about. The issue is that if that provider is, if the individual is of such a distance, then that provider does have a responsibility. If I live in Chester County and I'm seeing a provider in Erie, but I want to see, I change my mind, or clinically you determine I'm becoming dysregulated, there's an obligation on that provider to be able to get me into an in-person clinic. So
Correct.
I would say the addition is that if you are taking on a client because you do, you serve a unique population and you're very skilled in that population, but that person needs in-person services. It's on there is an expectation.
Okay. Thank you.
Is that really the only comment? Oh, great. Okay. Daniel? Oh, no, Ellie has
Hi.
number one. Sorry. Sorry,
Oh,
Daniel,
okay.
you're number 3. Ellie's
All
number
right.
1.
Hi, I just wanted to follow, there were two things I wanted to follow up on, if I may, with what Beth said. So just to confirm that we're not exclusively to the outpatient licensed psychiatric clinic, but a community-based private practice practitioner could come into network, is my understanding, and they would say right off the bat, I'm only going to do telehealth. And when I see a member, I say, I only do telehealth, and then the member can decide whether or not they want to see me. But if something clinical would emerge, as long as I had the ability to get the member to an in-person service, that would be acceptable. I just want to make sure that I'm clear on that.
You know what? I think that point is a point that if it's not clear now, this is the conversation we want to have to make sure so that it is, when we talk about what should be this slide that's up, what should be permitted from an audio only perspective, or sorry, from a telehealth perspective, are you advocating that that providers should be able to be telehealth only, but what about their responsibility if a person decompensates and it becomes clinically appropriate?
Right.
Because I'm not here to tell you we're working on another telehealth bulletin. I guess I want to say that. So I'm not here to say this is, I'm here to say, what do you think it should be before we issue the next bulletin?
Got it. And then just to share the only other consideration with that, I mean, obviously there's scenarios we've seen that it's clinically beneficial, and then others that we would not support. I think probably one of our bigger concerns might be having some type of parameters about telehealth providers coming in from outside of Pennsylvania, that it might be more opportunistic. And they'll promise, they're able to deliver certain things, but maybe, when it comes down to it, can they or can't they? So it's just a caution on that.
So what do you think? So Ellie, what do you think it should be? What do you think? I mean, that's what this conversation is about. What do you think we should do trying to increase access, but also protect folks using services to be able to have in-person services should it become clinically appropriate? What do you think the rule should be?
I can't say for certain, but I would think at a minimum an affiliation with a PA-based on-site clinic or clinical provider, that they would have some type of relationship if anything would arise. And then also, unless they were, I think it gets a little bit, what we have found that can be a little bit complicated throughout this period is the idea of when you will permit someone to do telehealth only. And there's been language that it's when I'm a specialty provider or when it's the member's preference. But then we have the average provider coming in, well, can I do that as well? And what defines me as a specialty provider that I would be entitled to that same service versus I want to increase my service area?
Yep. So what should the rule be? I know, I agree with everything you're saying. I mean, I think you're making great points. It's just, how do you strike that balance? So anyway, you can think about it. Folks can think about it. I think that's what we're trying to get from all of you, because these are the debates. These are the debates we have. Like, we want access, we want specialty, we want we want peer and family choice, but we want to protect the providers we have from folks who just come in and will take, certain clients. And so, but trying to figure out what the next telehealth bulletin should say, once again, with the framing that there's some things we can't do anything about because of federal payment regulations. Even on the state statute side, we have some hope of changing things, right? If we don't like something, but on the federal side, we remain very clear we have no ability to change. So if you want to think about that, Ellie, and if you have thoughts, we can go to the next person because we got a line of folks.
Thank you.
Yeah, absolutely. Tamara Williams.
Hi, good morning. Dr. Tamara Williams from Montgomery County. So a couple of things. I agree with the affiliation. I think the rules are fairly restrictive, and it discourages some really good providers who are based outside of Pennsylvania who offer high quality tele services from doing business here. And so I think they are sometimes also discouraged by having to work with a partner, and sort of what the structure of that affiliation might look like, and also what their liability is in terms of that affiliation. And so I think some guidance in terms of the how that affiliation should be structured would be helpful for others looking to do business and provide access to telehealth service who are based outside of Pennsylvania. And then the other comment I have / question is just around your second bullet point there in terms of the service type. So I just wanted to make a comment about peer services. We've had some discussions with folks who, if there are waiting lists for outpatient clinic services, they really view the peer service as a nice interim. It's definitely not a replacement for the type of treatment that they can get in outpatient, but I think that it would be beneficial for people to have a higher degree of access to peer services via telebehavioral health. And that also segues into a recent conversation we had with an organization that offers peer sort of counseling it's fully online though. and it's moderated, and assessments take place by licensed clinical staff. And it was unique because, people were saying that while they were waiting for an outpatient service, something like that would have been nice or helpful to sort of tide them over until they were able to get into the level of care that they wanted. But we're really having trouble sort of figuring out how to pay for something like that. It's we would really like to make it available to folks in Montgomery County, but again, are just struggling on where that fits in terms of our current regulations. So, not an answer, just kind of throwing that out.
Yeah,
And if
yeah.
folks have other thoughts, would
Yeah,
appreciate
thank you,
it.
Dr. Williams. And I do want to use this opportunity to make sure everybody knows that our spa has been officially approved and is on the DHS website now, that the standard to become a peer support certified peer specialist in the Commonwealth of Pennsylvania is no longer that you must have a serious mental illness and identify to the world as such. It is now that you have lived experience with a mental health diagnosis. So that that is the standard in the majority of other states. Obviously, we were an early adapter, but our window was pretty narrow about who could become a peer support specialist. And so that has officially been changed. And we're working on releasing the peer support bulletin. But just so folks know, people can now sit for the test. That's the definition now. Okay. Now, Daniel, sorry.
Hi, good morning. This is Dan Eisenhower from Perform Care. So I'm going like all the way back to the beginning. So of the presentation. So my question is, I think what you're saying is that OMSAS sort of needs to issue a new telehealth bulletin to address, I think, two main things in the clinic setting. So when Act 98 was passed, it allowed audio
It does
only
allow,
to,
yeah, you're right. It
right.
does. The act does. You're right.
So this
But
is
the
gonna like,
regulations say they
right, I
don't,
got
so
it.
we have to
Right.
fix
So
it.
right. So the federal regs need to address, I think, two key issues. That's just what I want to clarify. So one is audio only is not permitted, and then the four wall rules, one has to be in. So I just wanted to like level set, make sure I understood. So what we're hearing today is OMSAS letting us know that like we have to make changes to current practice.
Right, but audio
And
only is in our state, we were showing the regulations, audio only, and this is my mistake here. Audio only is in the state statute, but it's not permitted in the regulations, which causes a lot of confusion. So we have to
got
be
it.
clear
Right.
about that.
Yes.
And there's the federal payment regs do make it very clear that someone must be in the clinic, and we don't have anything that contradicts that. But in the land of telehealth, that became questionable whether it was always happening, that one of them
Right.
was in. And so we're trying to figure out, though, for providers of services, which that's my 11 o'clock is with providers, is that going to be, do we need to explore within, the rehab option of the state plan, which doesn't have the four wall rules? Is there a need to expand or explore another service? Just like, that's why these questions are here, is like, and that's why that level setting was here, is that, trying to make sure we understand the federal payment regs, but
Right.
also think outside the box of, yes, we need to issue a new telehealth bulletin that is from now, post-COVID, post, what
Got
is and
it.
is not.
Okay, then
So,
just one quick suggestion. I know OMSAS
yeah,
doesn't usually do this with bulletins, but like with regulations, you give us a comment period. This, like, I hear what people are saying, and like speaking for myself, I need a little bit of time to process the options. And this one might be one where it's good to offer like a brief comment period to the proposed bulletin after you meet with providers and consumers, because I think it does represent a bit of a change. And I just think like sort of sorting through all the clinical flexibilities and the like waiver flexibilities like Beth and others have talked about, I think it would be important for us to be able to like see what's proposed and react to it a little bit, like say this makes sense or maybe tweak this or that. Just a suggestion. Thank you.
yeah. Scott?
Good morning. Yeah, just One's an ask that, kind of similar to what Dan was talking about. It would really be helpful as we sort through all these iterations, and I don't mean that in a negative way. It's just what we're all dealing with. If OMSOS or someone could create a chart that would list all the various services and how, what is allowed with telehealth, what is disallowed because of the feds, what does the act say? It would just, and then the one that really confuses me is when a waiver is being requested, because there seems to be, waiver seems to be a lot of what is driving some of the confusion, because who has a waiver, who doesn't, what needs a waiver, what doesn't. And I know that may be a little tedious to put that together, but I think it would be extremely helpful once the dust settles down as an easy reference chart. As far as the having to be an offer, a face-to-face, or not face-to-face, but in-person service, I am very concerned with some of the out-of-state providers or even out-of-region providers, such as the Erie example that was provided earlier, where you could have a clinical relationship being built with an individual, and that person clinical needs change and they really need to be seen face to face. And I'm very concerned that the answer would be, we'll refer them to another provider who can see them face to face within your network, because one, you don't have the relationship, the clinical relationship, and two, those providers are going to be taking very difficult people who've already been engaged. It's kind of like the old cherry picking. And I really have concern with allowing out of state or out of area providers to do telehealth. And that person may say, yeah, I'm fine with doing telehealth, but things may change. And then you just, in essence, push that individual to a local provider to where they live, and what happens at that point in that clinical relationship. And if they're stabilized, then do they go back to the telehealth folks? I think it could create some, I think, really destructive clinical dynamics with individuals whose mental illness or even substance abuse fluctuates, in that relationship. So I just would be very cautious of allowing that to occur.
So Scott, I have a question, because I have this battle in my brain, and I'll see where you go with it, is that there's the battle in my brain between, if, especially younger people, right? I mean, I have children in their 20s and they just simply prefer telehealth everything. And if, and I think everyone knows I have a child on the autism spectrum who's transgender, who has 2 or 3 specific mental health diagnoses, and they need a very specialized provider. And so I guess I struggle with, do we allow specialized that someone who can work with someone with the uniquenesses of my child, even if that means that if they want to be seen in person, it's a 2-hour drive, or do we not allow that? But then the ability to meet the uniquenesses of someone with layers upon layers. So I struggle, because I also agree with you about trauma, right? The majority of folks, I mean, the medical director of NAMI National says that 80% of the expression of a mental illness is connected to trauma. And therefore, how hard is it to start new relationships, therapeutic relationships? So I hear exactly what you're saying, but I really don't know where to fall. I struggle where the right place is to fall around individual choice with someone who, because all therapists are not the right therapist for somebody, right? And, so I hear you, absolutely, but I don't know where but then we're eliminating choice for people on MA in a way that's not eliminated for people with private insurance.
Well, I'm not quite sure. I'm not as familiar with private insurance, what standards of quality do they have in their provider network or not. I think that one of the ways to approach this is, if a provider is presenting to come into network, I think as Beth was talking about earlier, that's something they need to explain in their request to come in. So how do they deal with an individual that they are solely engaged with telehealth, who is in need of or is requesting to be seen in person? I think it does somewhat fall on the provider to have to build that into their treatment model or their practice model, uh, both from a quality, I think even from a liability perspective. So it may be that that's similar to the way, in the early days, Dan and I, when we were working on the telepsychiatry before all of this came to fruition, that was one of the things that the plan had to have. How do you deal with certain things, because they will come up. And I think those are all critical pieces that I think the provider who is proposing it needs to be able to answer and be considered. So that would kind of be my suggestion to your statement there. And then also with the issue of specialty access, that was things, I think it's true of any network. If you're looking at your network capacity, are there geographic areas that there is limited access for individuals? Obviously, that's in person, but also specialty areas, in tracking and looking at your network database, do you have individuals, adequate number of individuals who serve certain populations, and you should identify that that's a needed area, and possibly even reaching out to providers who offer that service and see if you can bring them into network because you're lacking in that. So it could be, really be driven by, what your network capacity is and what are you in need of. And then I know this comes up a lot, and I'll end here. Is we still get really concerned with discrimination around choice and access, and we're dealing with a situation in Upper Dauphin right now where Upper Dauphin has very limited internet or good internet connection. And it also is a lower income area of our counties. And so are we creating choice for individuals that some individuals, due to where they live and due to their economic situation, can't afford it? And therefore, many times those individuals also have difficulty access to transportation. So I think we also have to be really careful that we aren't creating a two-tiered system, those who can do telehealth and those who would like to but can't.
Well, and I want to just add that, we haven't answered all these questions, but I do want to say one of the next slide has the question of what services should or should not be permitted to be delivered via audio only telebehavioral health. And so that's a whole nother, to your point, the CMS talks about audio only as an equity issue for folks who don't have access to, high speed internet or are challenged by the ability to use platforms. So, but I'm going to just go back and then we're going to have Mary talk, but both the questions about what services should or should not be permitted with audio only, and the previous slide questions about what service types, do you think service types should define what services can be delivered and what percentage of services can be delivered via telebehavioral health? So those two questions, as well as the audio only, are, questions we are looking to get your perspective on. Mary, Lynn?
I guess from both a county perspective and as a provider, we are an outpatient clinic ourselves. I guess the reality of trying to find psychiatry has really limited our ability. Finding in person versus telehealth has been huge, and we're a pretty rural community. So we've almost been forced to have to find providers that aren't necessarily in the state. So I guess that's more of a statement, I guess, but in response to your questions is we're looking for as much flexibility as we can possibly get. Let's just put it that way. And to your point about audio, yes, I'm looking for all options possible based on internet, based on rural, based on lack of transportation, based on provider shortage, all of that. Thank you.
Yeah, and I think I will say back to answering Scott's question about waiver and the fact that we've been granting waivers. That is what ended up on the psychiatric outpatient clinic side. We continued to receive multiple waivers to ask to flip the advanced practice professional as the person who did the in-person services and the psychiatrist who did their time via telehealth. And so that's the waiver we've issued multiple times. That doesn't alleviate the fact that the psychiatrist must be seen as the clinical director of the clinic, and that, because that rule, how much in-person time by the advanced practice professional or the psychiatrist is our rule. The fact that the physician must be the clinical director of the outpatient rule, that is a federal rule. So just to clarify, and I hear you, the more flexibility and especially with audio only. So back to, because no one else has their hand raised, back to percentages or services. I that, and I know these are really challenging questions, because that's why there's, we're having this conversation is that, and you can disagree with me. But like from my perspective, if you're 302, your service provider should have to be in person. It's a high intensity service and you don't have a choice. Mobile crisis should be in person. It's mobile crisis. But peer support, the request to have more time of peer support, be able to be telehealth, I could see how that makes sense. So that's what we're looking for, perspectives you have on that. When we talk about different service modalities, we've started that chart that you talked about, Scott, because I wanted it as well. And so I have a first version of that staff have made for me that kind of say, what can we, because it was kind of making sure we knew what we could and could not waive, so we didn't violate any federal payment rules. But does anybody have any thoughts about that? Because all services are not the same. So saying, 50% of service delivery for peer support could be telehealth is not the same as, so what about, services where people don't have the choice because they're involuntarily committed? Yes, Sally.
So Jenna, I guess I feel like if we apply a percentage to the percentage of services that can be telehealth, it's going to be arbitrary, right? We're just going to pick a number and apply it. I'm not sure what we would base that on. And I guess for me, representing the rural counties, as Mary Lynn said, we're not just looking for more flexibilities necessarily in clinics, but across different lines of service.
Yeah.
I guess I struggle with, is it more important to deliver the service, even if it's telehealth, than to have the person not get, like, what's our point? If the person's not going to have the service if it's in person, but they would with telehealth, I'm not sure what we accomplish by restraining the telehealth stuff.
Sally, what service won't they have other than a psychiatrist?
Well, family-based. We've had a lot of resistance from families since the COVID-19 pandemic to people coming in their homes. So what about family-based? I don't want it to be telephone only. It is supposed to be a higher in the continuum, right? Higher acuity families. But if we don't engage the family at all because we insist that it has to be in your house, have we accomplished anything with the family? So I'll go back to Mary Lynn, flexibility and balance here. If people aren't getting service because the barrier is the way that the service is delivered, it seems like an easy barrier to remove.
Right. I think the challenge, though, from my perspective, is that when is the barrier, the decision being the service recipient's decision to make and not the provider's decision to make outside of the hold that psychiatry has. And I say that once again, when I hear that mobile crisis providers are choosing to do a telehealth visit, I tell you, law enforcement is going to end up called, so that totally defeats the whole vision of creating a crisis system. So
I don't know that I necessarily agree with that, Jenna, because before lots of our areas had mobile crisis, they had telephone only. And law enforcement wasn't involved in multiple telephone crisis calls that were taken.
Right, and we still have telephone. I mean, we have
Right.
988 and we have county crisis lines, so that still exists. I'm talking about the specific two-person teams under the SAMHSA vision of the crisis system that we are working to build. So that is a diversion from law enforcement engagement. I don't know if you go by Jeffrey or Jeff, so I'm going to call you Jeffrey so I don't get.
Hey, I go by either, so either works. I just wanted to echo, I think, what's been said. I mean, I think we really do need to think about optimizing access and limiting sort of what I would put forward at times kind of arbitrary regs. I mean, one way that I think I've thought about this, and it gets back to some of that discussion about what goes on in the commercial space and others, is I think we should make it, providers should have to make it abundantly clear what their service availabilities are. And our members should have informed choice about what those options look like. I mean, I think in that way, we empower and optimize member agency and choice. And I think, frankly, we avoid being what at times is paternalistic. I mean, in sort of the service options. I think providers have an obligation to inform what they can or can't offer, and members have the opportunity to choose that. Like was brought up, there are many cohorts who would prefer exclusively, tele or virtual service delivery, and they should have that option. And I think, again, as long as we're clear, I put that forward in that one way to sort of think about this is putting the sort of onus on communication from providers to members, embracing informed consent and optimizing member choice as sort of prime outcomes of what we want to accomplish with this, all in the service of, I think, promoting access. So that's, I think, sort of the way I've thought about it.
Yeah, and I think promoting access is everybody's goal. The challenge is that because, the goal is to listen to all perspectives. When I hear that, a young adult wants to see somebody and they're told they can only have audio only counseling and they're not comfortable spilling their, life story to someone they can't even see, and that's where the trying to figure out how we make sure that it isn't the choice of the provider, it's the choice of the service recipient.
But isn't that something that, I mean, at the point of outset, at the point of triage, should be said, we're an agency that only provides services via this modality. If you're interested in seeing someone in person at this point or down the line, we're not the provider for you. I mean, then there's a choice. It's transparent, it's frank, but it potentially expands the numbers of providers in the mix or treatment options.
Yeah, and I think, Tina just posted a point about, I agree, with what you're saying and what Tina agreed with you about related to increasing access, but then the challenge becomes, how do we make sure that that we still have in-person providers that folks who prefer that can go to? Or does the market change so dramatically that everything except psychiatric outpatient clinics, because they can't, but everything else is telehealth, regardless of what your preference is. That's all that is available to you. So it's interesting to me, I'm not hearing any differentiation by service type. Like when I said, if I'm 302'd, I want the providers that I am working with to be required to be in person because I'm required to be there, not by my own choice. And I heard definitely the thing about peer support, a desire to have more of it be able to be telehealth. Those are the only two service modalities and then family-based, the ability of, but Scott, you're going to say something.
Yeah, thanks. I apologize. I didn't want to talk too much bringing this in, but I think that one of the things is if a service is defined as being mobile, so mobile mental health treatment, mobile crisis, then how do you do telehealth? You're not delivering the service as the service is defined. So I would think any service that is defined as being mobile, it has to be done mobile. Now, to Sally's point, I think you can certainly have a combination of in-person, especially home-based, IBHS, family-based, those services, but be able to have a combination of that. I think that you miss an awful lot clinically and in that therapeutic relationship of not seeing what's going on in the home. I think that is one of the real strengths of family-based. It's that the team gets in there and really better understands the dynamics that are going on there. But it doesn't mean it has to be totally. So I think that really, I don't think that other than mobile services and obviously 24/7 services, I think that anything can use telehealth. I think it just needs to be a combination of both in-person and telehealth. And that should really be decided by the clinical team or individual and the member or the person in the family to really determine when that makes a lot of sense to do that. And that, again, I think to me, it's ultimately the relationship of the provider and the individual or family that's in service to really determine how that best meets their needs. And it can't be one out of convenience, and it can't be one out of, to the betterment of the clinician, because it's easier on them. But I think that it really, even if it's kind of written into the treatment plan, that it defines how that relationship works. So I don't think there's any restrictions to it. I just think it needs to be clinically based and mutually agreed upon and how that would look.
Okay, thanks, Scott. It's 9:54. I want to make sure if somebody has been sitting on a thought that they really want to share, that we don't run out of time before you're able to do that. Because as I said, the goal of this is to hear your perspective, then we later hear the providers, and then later in the day we hear families and peers' perspectives to really think about what we do moving forward to provide options and protections and access. I think the word access is what we all are aiming for here. So anybody else have any other thoughts, things they've been wanting to say? Here's the RA account. Yes, Shannon.
I just wanted to chime in briefly on the 302s. I agree in best case that if someone has been 302'd, that they should be required to be seen in person. But being in such a rural area and such travel distance for the people that I serve, sometimes that's just not possible. And I think there should be exceptions built into that rule so that no matter what, a person would be able to get that service that they need. I'd like to be seen, if nothing more, to visually be on the other end of the computer and be able to talk to that person that has been in the hospital instead of just not going to the appointments and the follow-ups afterwards, because I see that so often because they just aren't going to the in-person.
Okay, thank you, Shannon.
Mhm.
Anybody else have anything that you want to add? Obviously, you have that email. Many of you have my email as well. I think most of you. So if there's, if you have thoughts, please share them. Like I said, we're having these conversations today, really trying to figure out, listen to all the voices and try to navigate what are really, as we can hear today, challenging, competing. We all want folks to have access, but concerns about making sure in-person services continue to exist. Lots of factors. Oh, Matthew, our closing word.
Hi, Matt Herford from Community Care. I just thank you for making available this opportunity for the feedback. I appreciate the the inclusive approach. I'm wondering if, to your point about an opportunity for follow-up, if you all would be willing or interested in putting forward some written questions that would be most helpful for feedback so that we could prepare some perhaps more detailed answers. Because I think the issues raised here touch on so many domains: access, member choice, billing, fraud, waste, abuse. They have, they're multidimensional, and the ability for us to put together some comprehensive feedback for you all in many cases would necessitate us involving other members of our teams. And in the case of us as a behavioral health managed care organization, coordinating our responses with our primary contractor partners. So we certainly welcome the opportunity. Yeah.
Yeah, and I was going to say, I'm not sure how I get this to all of you, but I know how I get it to some of you, but we will send this PowerPoint out because really, Shivani, can you go back 2 slides? The questions that we want to hear from you are here, these ones, what services and what if there should be percentages, and then Shivani, the next slide, of, what should be permitted to be audio only and what obligation should the provider have the recipient needs to be seen in person. Those are really the big framing questions we have. And so, because it's about different, on the other side, it's about different service types, because it's, that's where we get, mobile crisis is obviously different than talk therapy. And, in terms of from my perspective, at least, talk therapy is a very comfortable telehealth service for lots of folks versus if I'm in a crisis, I don't want to talk to a screen. And so, or that's what I hear from lots of folks. I shouldn't say me, but, so anyway, if you folks, if we will figure out how to get this to all of you, because there's 3 different groups on this call, and we would welcome thoughts, responses, however articulate or written out or not, just bullet point list, still fine with us, so that we can really hear from, and that's why we're once again doing this again later with providers and with families and peers to try to figure out this important, critical, yet so complicated issue as inclusively as possible, with respect, obviously, for any payment rules we can't change. So
great. And just thinking that other questions might surface when your conversations with both the providers and consumers and their families. And if those come up, we would certainly welcome the chance to respond to those if those are of interest.
Okay, that makes sense.
Thank you again.
Yep, absolutely. Okay, everybody. So it is 10 o'clock. Thank you all so much for your time, your consideration. We welcome additional comments, and I hope that you all have a lovely Monday. Take care. Bye-bye.